going to listen to him as he speaks about pulmonary injury and intensive care. Please join me in welcoming him.
All right, well, thank you. It's really a pleasure to be here. I also want to thank you, as Dr. Lean just stated, this visit is sponsored by FAIR, and I'm on the board of directors of FAIR. And I think, as you know, they now have an annual giving competition. And much to my dismay, we have been well behind the Medical College of Wisconsin the last 2 years, and you guys have won it yet again this year, I believe. And so it's really impressive. So thank you for that and for your support of FAIR, which, especially for the trainees in the audience, is an organization that supports research in anesthesia and is mostly funded by the ASA, but also funded by generous donors like yourself. So thank you. So when I was asked to come give this talk, I thought about it, and I always like to think about the audience and what they might want to hear about, what they might not want to hear about. And I'm at a stage of my career. I'm, in the latter stages of my career, I suppose. I've been chair now for about 8 years. And I was just telling Cindy that I was thinking back to when I was a resident and hearing from a more senior chair and who gave a pretty outdated presentation, which frightens me still. And so I tried to think about what I would talk about. And so the things that the lung is near and dear to my heart, I'm going to talk. So I decided to talk about that. And so make sure you do your QR code. We do the same thing. This is good. So I'm going to talk to you about perioperative lung protection. How do we keep the lung from getting injured, whether we work in the operating room or the intensive care unit? And I originally titled it A View from the Last 30 Years, which is how long I've been practicing anesthesia, if you include my residency training. And then as actually sitting on the airplane yesterday as I finished my talks, as I tend to do, I realized it's actually maybe a little longer than that. Believe it or not, I know I look too young to have been doing it that long, but it's actually been closer to 40 years. So in my disclosures, my wife works for a private healthcare firm. I won't talk about infertility. And I receive royalties from Elsevier. And mostly, I've been working on this for a really long time. So one of the things I do keep in my office is a little cup so I realized that it's closer to 40 years because I looked at my very first peer-reviewed publication that I could find in PubMed, and it was 1983, which by my math is 40 years. And this came from a laboratory I was working in to do my PhD. I did a PhD before going to medical school. My grades were not good enough to get into medical school the first time around, which was the best thing that ever happened because it got me to do some research. And I met some people in that lab that to this day are good friends and colleagues and mentors, like Janine Wiener-Kronisch, the former chair at MGH, and Michael Mathey, who's a legendary researcher in San Francisco. And I'll be talking a little bit about some of the work that I did with them. But sort of shocking to me to see how long ago this was. I do give a talk that relates to this, which has popular culture moments from different years over my career, which is fun, but I'm not going to do that today. I also keep in my office a little cup that has my ID badges from ever since I was at UCSF. So I think this is right around then, around internship. So I used to have hair, and I looked younger, believe it or not. So if you look back to the history of mechanical ventilation, you can go quite a ways back, perhaps the 1500s, when Vesalius, who is the gentleman pictured here, realized that an animal that had probably fallen on the side of the road and died, they noticed that it wasn't breathing anymore, and if you could take a reed, as you can see shown here, and if you put it into the trachea and blew on it, that sometimes that animal would then recover. It's probably also the first demonstration of ACLS, and this is in the 1500s. This is around the time when the circulation was first being discovered, or not discovered, but studied and trying to be understood. And really our role in all of this, and you should know that anesthesiologists began critical care, was during the polio epidemic. And I will say that Hannah Wunsch, who's an intensivist now at Weill Cornell in New York, just published a book and I'm blanking on the name of it, which talks about the polio epidemic, but it's really good reading. I recommend it, because this was the first time when we got involved in taking care of patients outside the operating room. So it was clear these patients were weak, they couldn't ventilate adequately, and the initial way they were supported is what you can see here. These are called iron lungs or cuirasses. And what's interesting about them is you can see they're all lined up here. People are lying on them, and in fact, I'm not really going to talk about ventilator-associated pneumonia today, but in this setting, you're probably not going to get it because you don't have a plastic tube down your trachea. Now, it was claustrophobic, it was difficult, and in fact, what you really wanted was one of these nurses who was really fast in doing whatever needed to be done in terms of bathing or other nursing care, because of course to do that you'd have to open this up and break the seal of the cuirass to do those things, and you would stop ventilating. But of course with polio you have a lot of muscle weakness, and so these machines were able to ventilate you. And in fact, this situation then led to the first tracheostomies. And what would happen is that patients would get a tracheostomy, and then a medical student would be seated at the bedside in a chair, and they would squeeze a bag and ventilate these patients for 24 hours straight. There were no work hour violations in those days, and I suppose the residents did some of that as well. So if you think about how the lung can be injured, there are really four major areas that we will discuss. The first is barotrauma, or pressure injury, and certainly pressure is one of the things that we monitor quite closely in the operating room and in the intensive care unit. Volutrauma, excessive tidal volume injuring the lung, and we'll spend a little time on that. Atelectrauma, which is when the lung is constantly collapsing and then reopening, you can have injury. And then finally, biotrauma, which is really that all of the above three etiologies which cause a release of inflammatory mediators, mostly cytokines, into the lung itself, into the alveolar space, but also into the circulation, which might explain why someone who comes in with acute lung injury can then develop acute kidney injury very rapidly. So if you look at the alveolus, it's a beautiful thing, at least in my eye, and here's an electron micrograph of a single alveolus. I don't know if I have a pointer, but that's okay. And in the middle, you see a couple of red blood cells. It's a very thin layer between the alveolar wall on either side and the red blood cell. That's good news, because we want very rapid exchange of oxygen, and then carbon dioxide can exchange as well from the plasma out into the alveolar space. But then you can also imagine a couple of things. One is that pressure on this delicate structure from squeezing from either side can have a big impact on pulmonary vascular resistance. And of course, also increasing tidal volume will stretch this delicate structure and can tear it, right? Because it's such a delicate thing, and we all know that. So barotrauma is parenchymal injury to the lung, which results from high intrapulmonary air pressure. So we're going to talk a fair amount about this, because I think there's often misconceptions. I was talking to Jens Kronbach on the way in. He asked me a little bit about when we do bariatric surgery and things like that and have very large patients. If you want to ventilate a large patient, you have to have high pressures to lift the chest wall. The chest wall is heavy. But as you'll see, those patients don't get lung injury, and we'll talk about why. But if the pressures get very high, we get very nervous, appropriately so. But again, I think depending on the circumstances, that may be quite injurious, but it may not as well. So when I was training as a fellow in the 90s, when we managed patients with ARDS, it was pretty frightening, because they would get a lot of barotrauma. I remember patients would get 6, 8, 10, 12 chest tubes because of recurrent pneumothorax. And I haven't seen that in many years. So what happened? Why don't these patients have that? And at the time, we just said, well, this is a terrible disease. It's eating away at the lungs. They're getting pneumothorax. There's nothing much we can do about it. And of course, as you'll see, we were giving too much tidal volume, which was the reason. But you would see a chest CT like this, and there's a couple things that you should notice. One is that on the lower right, maybe there's that. Oh, all right. Here, here's an obvious pneumothorax here. But you can also see, for example, here, there's a large pleural effusion. And there's a lot of atelectasis in the dependent, this patient is supine, in the dependent parts of the lung, and much less as you move up the lung. And that will be a bit of a theme when we talk about prone ventilation. So volume trauma is direct injury to the lung from overdistension. And again, it's really regional variability that's causing this. If I were to go back here, you can see that there are parts of the lung that are very atelectatic. Here, but there's other parts that aren't. And so you can imagine if you give a breath to this lung, that it's going to distribute itself according to regional compliance. It's very compliant up here, not very compliant down here. And so the breath will disproportionately go to the part of the lung that's more normal and eventually make that more normal lung become less normal. So nevertheless, high pressures will cause some lung injury and stretch that delicate alveolus that I showed you. And when you stretch that delicate alveolus, it becomes more permeable, understandably. And so this is from Guyton and Parker. Many of us use Guyton's physiology. I don't know if that's still a thing. It is? I got some, well, I'm seeing some more experienced people saying yes. And they took, this is a lung from a dog. It's isolated, so it's sitting out in the lab, and it has air, atmospheric pressure on the outside. But as they inflated this lung, you can see that, and on the left is the permeability of the lung, that this KFC here is permeability. And you can see at a certain point, when you get to between 35 and 40, the permeability of the lung would increase. And that is true. And even in humans, you can see some increase in permeability starting to happen with very high inflation. However, this is a lung that's sitting out in the atmosphere and not inside the chest, where it's nicely protected by the chest wall. So a little bit more on that. And what can happen when you overdistend the lung is then you can get perivascular hemorrhage, and that's sometimes you can see what the radiologist will say is fluid cuffing, and that could be pulmonary edema fluid. That the lung is beautifully built so that when pulmonary edema occurs in the lung, there's a pressure gradient from the alveoli to the large airways, and it sucks the edema fluid away from the alveoli that are exchanging gas, and sucks it into these perivascular and peribronchial cuffs. And that's actually in that 1983 publication I showed you. This is work I was doing for my PhD, where we were able to measure pressures in different parts of the lung and show that indeed pulmonary edema fluid is sucked away from the gas exchanging regions of the lung. And then atelect trauma is the recurrent collapse of the lung. So that could be because of low tidal volume, and it's in injured lungs, their surfactant function is poor, and of course in the premature infant lung, they have no surfactant depending on when the infant is born. And one of the really key discoveries in our field was in part by George Gregory at UCSF and Mary Ellen Avery at Boston Children's, and John Clements, who was one of the people I did my PhD with, who discovered surfactant. They found that premature infant lungs were very stiff, had very poor compliance. We tried to inflate them. And an infant who had unfortunately died from some other cause, but that was full term, didn't have such stiff lungs. And they decided to wash the lungs out and see what was in there, and realized that there was this surfactant protein that was lowering surface tension and led to the development of exosurf, or artificial surfactant, and which has saved hundreds of thousands or millions of premature infant lives. But in the injured lung, of course, the inflammation will inactivate the surfactant that's there and make the lung stiffer. And the constant cyclic collapse of the lung and opening of the lung is inflammatory. And so with that inflammation, you're going to get release of inflammatory mediators, both into the lung itself, into the alveolar space, but also into the circulation, again, causing hypotension, sepsis-like syndromes, and injury to other organs, and in particular the kidney is the most susceptible to that injury. So that's what we call biotrauma, which is injury to other parts of the body from the initial lung injury. And it's one of the reasons why acute lung injury is so harmful. And much work has been done looking at this. There's a lot of overlap in, of course, the mechanisms and mediators that cause this type of injury with severe sepsis. And in fact, whether you need to really differentiate those or not is unclear. But of course, The vice versa is true, where if a patient has, say, abdominal sepsis from a perforated appendix, they can then develop lung injury from those same things circulating into the lung, activating macrophages that are in the alveolar space and also in the vascular space, and they will then injure nearby tissues in the lung. And of course, the double whammy is that mechanical ventilation of the lung is not good for the lung, right? And as you'll see, for the most part, the work that we do every day in the operating room doesn't injure the lung, and I think that's reassuring. And I'm going to show you a lot of work that tried to see is there's the way that we ventilate patients in the operating room, are we making them worse? And I think spoiler alert, probably not. That's good. So maybe I can just stop now, but I'll keep going. But we do worry about, are we taking a lung that has been essentially primed for injury because of other ongoing things? Or let's say you're doing a vascular case, and of course, aortic clamping and unclamping is very inflammatory. Should we be thinking differently about how we manage someone who's having aortic surgery than someone who's having a more routine orthopedic surgery or something like that? And this is work from Michael Mathey and Lorraine Ware, who did a very nice review article in the New England Journal looking at who are these inflammatory mediators, how are they activated, and much work, thousands of publications looking at these, and many clinical trials, for example, trying to neutralize some of these things like TNF and IL-1 beta, and essentially can summarize all of those. You know that we're not treating acute lung injury with any sort of intravenous therapy, including steroids. And so, as we have learned over the years, and I've been involved in many clinical trials with acute lung injury and sepsis, we need these things, right? We need our IL-1 and TNF. There's nothing in there that is extraneous. These all are part of our host response to the infection and to the inflammation. Some are pro-inflammatory, some are anti-inflammatory. Many of them are necessary to fight secondary infection. So Mother Nature knew what they were doing. I'm from California, we'll say Mother Nature, they. They knew what they were doing because we need all of these, and we just don't understand the balance that you need in all of these things particularly at different time periods of acute injury. So to go back to our CT scan, I showed you they're very different. In one patient can have very different parts of the lung that are in a different condition in terms of inflation and atelectasis, with some normal parts of the lung up at typically at the non-dependent parts of the lung, non-gravity dependent, and then the dependent regions down here. So, what can we do about that? Because we know that atelectatic lung doesn't work very well for gas exchange, so are there some things we can do? If you look at the pressure-volume relationship on the ventilator and bring up the ventilator waveforms, it looks a little bit like a penguin. The lung, and the slope of this line at any one time is lung compliance, so when the lung is collapsed or very low tidal volume, it's very stiff, and then as you start to recruit the lung, it becomes much less stiff, as you can see here. And the analogy I would use is those little skinny kids' party balloons, right? They're really hard to start to blow them up, and then it's very easy. And then, of course, what happens? They'll pop. And so we inflate the lung, and then the lung deflates. And, of course, it doesn't deflate on the same line, and that's hysteresis, as you knew from medical school. Now, as the lung gets injured, however, it changes, and the whole thing sort of tilts over to the right, becomes even stiffer, particularly at low tidal volumes. There's more atelectasis. It takes more pressure to start to open the lung, and we call that P-flex. And then there's a region where the lung is much more flexible. But then there's another region here at very high airway pressures and tidal volume where it becomes stiffer again, right? The slope flattens out again, and we call this like a penguin beak. And this is likely where a lot of injuries are occurring. So the lung is now being torn and excessively ventilated. And then it comes down again. So the idea of protective mechanical ventilation was, well, we know that this repeated collapse of the lung is bad, and we know that this excessive distension of the lung is bad. So what if we were just to avoid those two? And the way we could avoid it was by if we increase PEEP, in other words, we don't let the lung drop down below this level here, all right? And if we limit the tidal volume, and that we do here, that we can protect the lung by cycling through more frequent breaths at a tidal volume with a higher level of PEEP, and that's lung protective ventilation. And that is something that's quite easy to do. And I think for probably people that are training now, it's like, yeah, that's what we always do. But it's not what we always did, because what used to happen was when patients were sick in the ICU with acute lung injury and they were hypoxemic, if you increased the tidal volume for a little while, the PO2 would go up. And how could that be bad? It's low. We want it to be higher. You increase the tidal volume, the PO2 goes up. You must have done something good. But it turns out you didn't. And I'll tell you why in just a moment. So one of the important studies this is a rabbit study from Dreyfus in Paris, where they said, well, is the problem now that we have high pressures in the lung, or is it high tidal volume? So what they did was they looked both at pulmonary edema and the protein permeability. And so they have one group which is high pressure and high volume, all right? And so they took the rabbit, left the rabbit's head outside a little plastic box. So they were able to give high pressure and high tidal volume, so really inflated the lungs. And then they had another one, which was low pressure and high tidal volume. Well, they put them into one of those iron lungs. So the head is outside. They created very negative pressure in the box, so the lung really inflated. But the airway pressure, the tracheal pressure, was zero because the head is outside the box. And then in the third group, they were able to do high pressure, low tidal volume, and they would wrap gauze around the chest of the rabbit and then give high pressure, and the lung would be restricted. And what they found was that when you restricted overexpansion of the lung, then you had less pulmonary edema on the left, and you had less protein permeability. So this is really a really key study in these rabbits, was that the problem is not the pressure, the problem is the volume. And if you limit tidal volume, you could probably limit the injury. So I was lucky, this is now the old guy reminiscing part, when I was a fellow in the ICU at UCSF, and the same people that I had done my PhD with, particularly Michael Mathey, was doing, I remember, when we were planning for this trial, which is, well, okay, the NIH gave a bunch of money to do a network trial looking at high versus low tidal volume, and I didn't think that was so cool at all. I wanted to do something, sexier with cytokines or some kind of thing like that. I said, really, that's all we're gonna do is just turn the dial on the ventilator and that's gonna save lives? It just didn't seem very compelling to me. But nevertheless, and there was a recent look back at the most impactful studies in all of critical care, and this was number one because it has changed practice. So this was just high versus low tidal volume. Now, it was easy to do because we just said, do this. The patient met the criteria, assist control ventilation, set the rate less than 35, and just try to ventilate to a pH between 7.3 and 7.45, and then they would be weaned using a pressure support wean and a set PEEP. Now, I will tell you, and I will argue with him often, because I was very involved in a lot of systems change in the ICU. I said, yeah, this is cool stuff, and the ventilator settings are important. Equally important with this, though, was that you had to wean the patients and ventilate the patients by protocol. And you couldn't just do whatever you wanted. And in those days in critical care, we loved it because since there was really no evidence for anything we did, we could do whatever we wanted. And now you couldn't anymore. You had to follow the protocol. And so I would say that was very important. And the protocolized weaning it got patients off the ventilator quickly so they didn't get pneumonia and things like that. And so patients perhaps in a surgical ICU with busy surgeons who didn't have the time to round all the time, we handed the management of this to the respiratory therapists and the bedside nurses, the people who are actually there all the time, and let them drive the ventilator weaning. And Wes Ely and others showed that makes a big difference. So protocolized weaning was really important. And this is, if I look back at my tens of thousands of slides, this could be my favorite, and I'll tell you why. It's because these patients who started very hypoxemic, this is PaO2 to FiO2 ratio, so on 100% oxygen, their PO2 was about 140, and then when they entered into the study, and look what happens on day 1 and 2 is that the high tidal volume people had better oxygenation. We must be doing something good, right? This is awesome. They're getting better. We turned up the tidal volume. But wait. By day 4, it was the same, because what we were doing was we were injuring these lungs and we were protecting these lungs. By day 4, the oxygenation was the same in both groups. And in fact, if you looked at ventilator-free days, and most people aren't familiar with that concept, nothing's free in healthcare, but what they mean is that you're free of the ventilator. So you want ventilator-free days. So the first 28 days that you come to the ICU, how many days are you not on the ventilator? And there was a huge difference. In the low tidal volume, 6 ml per kilo, it was 15, and in the 12 mLs per kilo, it was 6. Now, you would say, well, 12 mLs per kilo, you're just looking at really bad ventilation versus better ventilation. But there are many studies that show that this is very much a typical tidal volume that was being used in those days for mechanical ventilation. Not at all unusual, because again, patients were hypoxemic, you'd crank up the tidal volume. This is really, this was stunning. And when we looked at mortality prior to discharge, the difference was 30% to 40%. And in those days, and that wasn't, we weren't hurting people, because in fact, in those days, mortality was closer to 50% for these patients. So this couldn't have been a simpler study. Many studies were done to follow this. And essentially every single one showed the same impact, that when you use this protective lung ventilation, you save lives. One of the things that made it helpful was that we had agreed upon definitions. These are what are called the Berlin definitions. It's one modification. I'm not going to go to a lot of details, but it's easy to spot, right? So this is a patient who has hypoxemia based on a blood gas with known ventilator settings, and this was the update to these settings, as we said, what is the blood gas with standardized settings? Then they have acute lung injury if they have bilateral infiltrates on their chest x-ray. You're done. You've diagnosed it. And of course, what's happened, and that will sort of go us into the next phase, is there's sort of been a little bit of creep into other areas saying, well, if this is good for these patients, it must be good for everybody. And we're going to talk about that in a minute. So what about atelectasis? So I've told you that that's bad. Is that part of the problem? Can we work even more on the atelectasis piece and improve lives even better? Well, we do recruitment maneuvers all the time. You probably do it without even knowing. When your patient in the operating room is desaturating, you do sort of a little bit of a breath hold with a Jackson Reese, and it gets better. That's a recruitment maneuver. And you can formalize them more, but that's probably not necessary. But of course, you also know when you do a recruitment maneuver, increase intrathoracic pressure, you're going to have a problem with hypotension because you've increased intrathoracic pressure and decreased venous return. So this was an interesting study where they did CT scans. Again, this was a dog study where they took, these are lungs that are injured with what's called oleic acid intravenously. It injures the lung. And what they showed is that, again, do a CT, supine, that here's the heart, here are the lungs, a lot of edema and atelectasis. But if you recruit the lungs, if you slowly increase tidal volume, and up to a relatively high value, you can completely recruit the lungs. Now these same lungs here look like they're normal. But more interestingly is that then when you come back down the hysteresis curve, as we talked about before, they look better at a given pressure, let's say right here, right? Look how terrible this lung looks, and look how much better this lung looks, all right? That's the same lung, but on the deflation curve. So the thought was, well, if we just use more PEEP, maybe we can keep this atelectasis from occurring, and then that will help with oxygenation, et cetera. And so Gattinoni, a legendary guy from northern Italy, from Milan, did a study in the New England Journal. This is, again, quite a while ago, 2006, looking at 68 patients, and they all got CT scans, and they tried to look at how much of the lung is recruitable. And this was interesting when I first read it. I had to read it a couple times, so I didn't totally understand it. Because at first it says, well, if you have a low percentage, this is a low percentage of recruitable lung. In other words, if you look at the lung here and here, when they did a recruitment maneuver, it looks almost the same, right? Whereas this one, if you did a recruitment maneuver, it looked much better. And so you'd say, oh, I want to be in this group, right? Because I want to be recruitable. That sounds good. But it turns out it was just the opposite, because what was happening was that if your lung was already recruited on the standard settings before your CT scan, before the recruitment maneuver, it was a more flexible, more recruitable lung. If it took very high pressures to recruit your lung, it was injured more severely, and you weren't going to do so well. And so, in fact, and they showed this is mortality as a function of recruitable lung. The more recruitable your lung was, the higher your mortality, because it just shows you that in its state prior to the recruitment maneuver, it was already recruited. So if you need a lot of aggressive recruitment, your lung is more injured, and that finally sort of sunk in to my brain. Well, we all lived through the COVID-19 pandemic, and I think there was, I was excited that the New York Times thinks it's interesting about prone mechanical ventilation, and this was from the Times where they showed that Yeah, it turns out that when you position your body prone, it works a little bit better. This is, I guess, an evolutionary change based on our chest wall structure. And I think you also know that people coming to the hospital, particularly in New York where they were overwhelmed, well, they would just turn people on their stomach and their saturation would do much better. And they realized that this is a pretty simple maneuver. It obviously doesn't cost anything. It can be hard for the patients. It can be a little uncomfortable, but they were able to get patients who were just on nasal cannula and desaturating, looking like they're heading for intubation, but keeping them on high flow or nasal cannula, turning them prone, and they would do well enough that they didn't have to be ventilated. And so, what is that all about? Well, again, supine, if you look at a supine, the heart is putting pressure on the lungs. There's much more lung parenchyma posteriorly than there is anteriorly. So the heart pressing down on this compresses the lung, and we have more hypoxemia. But of course, if you turn prone, then the heart can rest against the sternum, and the lung can be recruited. And so, in fact, there's much more open lung, if you will. This is part of what's called the open lung approach, and will oxygenate better. And so, subsequently, this is, again, Gattinoni made a nice picture, which sort of shows in a model how turning the lung prone will allow much better VQ matching between open alveoli and the circulation, and much better than you get when the lung is supine. And so that's obviously something, well, simple is probably not quite true. We've all seen patients in the ICU with lines and tubes, and if they're larger, it can be pretty, and these tubes are tenuous. It can be sort of death-defying to try to do this. And in fact, there are machines. This is what's called the rotaprone, and this is actually, Jens will appreciate, this is actually Vince Liu when he was a fellow. You can see looking a little terrified. So we were trying to learn how to use this, so we had our fellow get inside this thing. We kind of thought it was entertaining. But even that, you can imagine the nursing person power it takes to be able to do this. But of course, when it was published when this work was published in the New England Journal, again from Gattinoni, you can see, I think in France everybody's thin, I guess from the cigarettes or something, but it's easier. They just turn people prone and supine, and what you can see when they published this in the New England Journal, it's called the PROCEVA study, that it was quite powerful, 475 patients. Now, you can have what's called a dose of proning, which is you need to do it soon. So they did it within 55 minutes of arriving in the ICU and being intubated, and they would do it for 17 hours a day, so it's a lot. And it might take a little more sedation for people to be able to stay prone like this. You have to be really careful with the lines and tubes, make sure there's no pressure injuries. And then they had standardized criteria for when they would stop proning, and that would be when the oxygenation was better and the FiO2 had come down. But what was impressive was the difference in mortality, 75% in the supine group, which is quite high, and only 38% in the prone group, so essentially half. And in fact, at day 90, this held up as well, highly statistically significant. And then the ventilator-free days also increased significantly. So this worked really well and is not a complex procedure, other than from the personnel standpoint, it is complex, but in terms of technology and other things, not so much. So this is something we absolutely went to during the COVID pandemic, and here's the Kaplan-Meier survival curve for that study. So this was pretty powerful. I remember when this came out, and and I presented this to our ICU nurses, and they sort of looked at me with their eyes wide and said, "How are we going to do this?" And you have to learn how to do it. You have to train people. You need to get help from your respiratory therapists and hospital assistants, et cetera. But it's something that's done. And thankfully, we were familiar with during the COVID pandemic, because we did lots of this during COVID, and I suspect that you all did as well. So as we think about this issue of pressure versus volume, there's been a bit of a change over the years to thinking, rather than thinking of them separately, that we think of them together in what we call driving pressure. So we know that we don't want excessive tidal volume. We want to keep the volume, the peak volume down, but also what do we do with the PEEP? And the optimal level of PEEP remains controversial. So one of my dear friends, a friend of Cindy's, Danny Talmore, has done a lot of work on this. And the idea is, how should we deal with PEEP? Is it dangerous because of the atelect trauma that I talked to you about, or is it not? And there's a lot of conflict. And one way to think about it is what's called driving pressure. And that's the difference between the peak pressure and the PEEP. And so when you have a big difference between peak, and that's really the inflation pressure, right? And we also call the driving pressure. So when that is large, you're probably injuring the lung, and when it's lower, not so much. And that's where we'll get to, for example, the large patient in the operating room. The driving pressure is not high. So how do you measure that? Well, you can put in what's called an esophageal balloon. This is a little, unwieldy, but you just put a balloon into the esophagus and inflate it, because what you're trying to measure actually is pleural pressure, which is also transpulmonary pressure. So alveolar pressure minus pleural pressure is the true inflation pressure of the lung. Maybe remember that from physiology, but it's kind of hard to do, and nobody really wants to do this. And I'll show you that we don't need to do it unless you're trying to do a study. So what was interesting was that Marcello Amato and others, and Danny and his group, and Art Slutsky at MGH went back and looked at all these patients enrolled in these ARDS trials and reevaluated the data and measured the driving pressure. And what they found was that if on the left you had patients who all had the same level of PEEP, but then had increasing driving pressure, right? In the middle, they had constant driving pressure, meaning that the PEEP went up at the same rate as the driving pressure, as the peak pressure. And on the right was where the peak pressure stayed the same, but the PEEP increased. And what they found when you looked at mortality was when the driving pressure increased, mortality increased. When it was kept the same, it was flat. And when the driving pressure decreased, the mortality went down. Now, you could say, well, that's, is this an association or causation? It's probably a little bit of both, but here you can see the relationship between driving pressure and mortality. So I think that was compelling to me to think a little bit more about the driving pressure as what we should be focused on. Now, I'm not going to go a lot into the study design and why did people need higher driving pressure? Maybe, well, if they were dying from hypoxemia, couldn't be rescued by ECMO, it may be what was necessary. But I think this is important to keep in mind. So that led to a series of studies to say, well, let's determine the best, PEEP strategy for patients with ARDS. And from JAMA, it showed that maybe it doesn't really matter. In other words, you don't need to put one of these esophageal pressure balloons in, because when you did very careful PEEP titration using one of these balloons, it was no different than just setting a table with standardized, and that's what we have in our protocol in the ICU, which is, when the FiO2 goes to 0.5, you increase the PEEP to 8. When it goes to FiO2, it goes to 0.7, you go to 10. And you can just sort of standardize it like that, and it doesn't seem to matter. But probably of more interest to all of you is, well, what do I do in the operating room? And so this was, been known for a long time. Why did we use high tidal volumes in the operating room? This is work from Henrik Ben Dixon when he was at Mass General, and subsequently spent most of his career at Columbia. So in 1963, full disclosure, I was alive at that time, and not many of you probably were. I didn't read the New England Journal at age 5, but it's okay. But what they noticed was when you had sort of monotonous tidal volume in the operating room, patients were intubated, they're probably getting curare and some other, other strange anesthetics. But that if you looked at ventilation would remain steady, as you can see here, the PaCO2 is steady, but over time the PO2 would fall. But then they also noticed when you gave bigger tidal volumes and inflation, then that would recover. So again, this is saying, hey, if we get bigger tidal volumes, then this hypoxemia will go away. There was no pulse ox in those days. You had to draw blood gas. And this was right about when the blood gas machine had been invented by John Severinghaus in San Francisco. Post-op respiratory failure is bad. It's expensive. It's a terrible complication. And so, in fact, the AHRQ, when the government looks at complications and quality of care, they look at post-op respiratory failure. There's 230 million anesthetics done worldwide, and about 5% of those will have post-op lung injury. Probably almost 3 times as many will have some sort of post-op pulmonary complication, and that's about 1 million in the US. And in this study that was published in JAMA Surgery, a multi-center study including a number of people from our institution, they looked at it was a multi-center study looking at ASA3 patients. These are all non-cardiac surgery patients, and tried to see, are there some things that might predict who's going to get a post-op pulmonary complication? Now, of course, we want things that we can change, that we can impact. So, for example, we can't do anything about it being an emergency, right? It's emergency. But, maybe the idea of we should think a little bit about colloids, and those have sort of fallen out of favor, fortunately. And then if you looked at continuous variables, yeah, high tidal volume seemed to be associated. A lot of PEEP was associated. Of course, a slow surgeon, you can't really do much about, highly associated. So you can just maybe flash this today if somebody's taking too long and say, hey, I heard this morning that slow surgeons cause patients to have lung injury. See how that goes. And of course, blood loss, which might relate to the slow surgeon, but nevertheless. But if you look at these, any single postoperative pulmonary complication increases both hospital length of stay and the probability of death. And so we would like to avoid these if we can. So there have been a series of studies, and I'm not going to spend a lot of time on them because I'll be able to summarize them, where they tried to then start looking at, okay, these are not patients, these are patients without lung injury having surgery. And the highest risk things, as you can imagine, are large laparotomies and vascular surgery. And so, for example, in 2013, Foutier did this study looking at, in the control group, they had high tidal volumes, again, 10 to 12 mLs per kilo with no PEEP. I have some issues with that. That's, again, a very high driving pressure. You know that now, right? The peak pressure minus, so driving pressure was high because of the low PEEP. And then the intervention group was a lung protective strategy with a recruitment maneuver every 30 seconds, holding a little bit of pressure to allow the lung to re-expand. And there's good separation between the groups. If you look at tidal volume, PEEP, everything that they tried to do, so that went well. The fluids were well balanced. That was important. And when they looked at the outcomes, it was pretty impressive. There was a big difference in outcomes between the group that had the protective ventilation and the group that had the not very protective ventilation. So this was quite impressive and really, I think, raised some concerns about how we were ventilating patients in the OR that were high risk with high-risk abdominal surgery. And here we are, if they looked at the probability of a composite event. Now, that's a little challenging. It means if you had any one of these things, the answer was yes, you had an event. So pneumonia, needed mechanical ventilation, sepsis, death. And so there was a big difference between the two groups. And there was a lot of controversy about the study and some concerns. And so they went right back to work and tried to repeat this. And so another group, European group, mostly based in Spain, did the same thing, but did it a little more carefully and had 4 groups. I won't go into a lot of detail, but they didn't use these for example, low PEEP strategies and have very high driving pressures. When they did something quite similar, they were unable, and to do very careful ventilator setting in these patients, they were unable to show a difference between these two groups. So at that point, I think there was thought that, well, let's reassess this. Now, you can't just do 2 trials, one that shows that this makes a big difference, and one more study that shows that it doesn't. So that led to a career for many people to keep doing the same thing over and over again. But much more recently, this is a nice study that comes from the Australia-New Zealand group in Melbourne, Ronaldo Bellomo, showing that in a single center trial of 1,200 patients having non-cardiothoracic surgery, and this was, I think, well standardized. They got 5 of PEEP, 6 versus 10 mLs per kilo, and again, looked at a composite outcome. And you can see that in this study, there was no difference between the groups. And so, and here you can see it. No, is there a trend that favors low tidal volume? No, none of these were significant. It could be fuel for yet another study, but I think you're going to have to do it differently. And if we had time later, we can talk about, I think this is an opportunity for something like MPOG to really be able to drive some interesting questions. But all you can do is derive questions that then would need to drive a new randomized prospective trial. And then another question that comes up is, okay, we're doing bariatric surgery now. The patient has a BMI of 60. What do we do? And I often find when I'm in the operating room with a resident, for example, they keep turning down the tidal volume because they're scared by the high peak pressures. Well, to go back to the beginning, you can't lift that heavy chest without a high peak pressure. But if you did put one of those esophageal balloons in there, you would see that the pleural pressure is high as well. The driving pressure is low. These large patients do not get lung injury because that heavy chest wall is protecting the lung from overexpansion. It's just fine. you have to ventilate the patient. You can't not ventilate them trying to avoid a high pressure. So you have to understand, is this high pressure because of overinflation, or is this high pressure just because I have to lift a heavy chest wall with the ventilator? So again, from the European group, looked at the same thing and were unable to find a difference in multiple outcomes when they used high versus low pressure. Now, what they did find, however, was that if you look at intraoperative events, when you used very low tidal volume, there was a lot of hypoxemia. So these patients did need some sort of gentle recruitment maneuver because they had excessive atelectasis. And of course, if you have high tidal volume, you're probably going to need vasopressors, right? Because that you've increased intrathoracic pressure to the extent that you're impeding venous return. So the last sort of study I'll talk about is what's called a PSI. Now, again, you need to have a few miles on you to recognize this. This is a Siemens ventilator, and maybe at San Francisco General they still have those. And so the little button that you could turn on a PSI. I used to do that when the surgery was taking a really long time, and I figured if I could have somebody PSI for me, I didn't have to PSI myself because I was tired. But anyway, all it is showing, if you look at the waveforms, is that it's giving breaths, and then what it'll do is it'll give a bigger breath, and it'll hold it for a little while, and then it goes back to what it was doing. And this is just a simple recruitment maneuver. So I was a little surprised, actually, just about a week ago when this study came out. Rick Albert, who's at University of Colorado, decided that they would do a pragmatic randomized trial of PSI breaths. So this is over a period of time when we've all been using low tidal volumes now across 15 academic centers and looked for risk factors for ARDS, 520 patients. And what they found was there was no difference in survival in this. This did not reach statistical significance. But there was a trend towards actually a successful extubation, or what they call ventilator-free days. And what you can see here is that there was a trend towards getting off the ventilator sooner if you did these PSIs in the ICU. I think, this, I don't know that this is going to change. I wouldn't run out there and start doing this right away. I think that the way that we ventilate patients in a modern ICU, which includes many other things that you need to control in these studies. For example, what is your early mobility program? Are you getting patients out of bed that are on the ventilator? You can ambulate on a ventilator, you can ambulate on ECMO, which means you're also giving a lot less sedation, which keeps you on the ventilator. There's a lot of things that go into this. And my personal opinion is that so I guess the last couple slides didn't come up. Well, we're close. I had a pretty picture of San Francisco, but that's all right. I'll just summarize here that I think that we have, defined safe ways to ventilate patients. I don't think that I came back in a number of years and said, what, we finally figured it out that if you do fiddle the ventilator exactly in this one way that adjusting PEEP, that you're going to really change mortality. But what I would say in summary is for patients in the operating room, I think tidal volumes around 8 mLs per kilo are fine. We have an alert system in our Epic that when it goes beyond 8 mLs per kilo, the row that shows you the tidal volume turns red. We didn't want anything, it wasn't like, some scary attending can run in the room and say, turn it down or anything like that. We wanted it to be sort of a gentle nod when we did it based on tidal volume, and it calculates 8 mLs per kilo based on ideal body weight, because we have that in Epic. I think that, moderate levels of PEEP between 5 and 10. When you have larger patients, you should use higher levels of PEEP. So bariatric surgery, I'm often at 10 or 12. There tends to be an abnormal fear of PEEP, but I think that those patients will do better than those that we use just 5 of PEEP, which tends to be a routine. And those patients, for example, do much better getting extubated when they're sitting upright, which is, again, as close as we can get to prone mechanical ventilation. It's early in the morning, which I had my slide. But I think the main things I want to say is that over many years of doing these types of studies, I think it's important that many of the things around that and how we care for the patients in the ICU now have a bigger impact than how you actually set the ventilator. But I think what we're hoping to do is go now use the MPOG database, do very large data analysis, and identify other questions around how we do this. But I think it's a good example of how we've done a really good job of improving the outcomes of patients. And if you look at every study, for the most part, that I've shown you, if you compare the outcomes of mortality and duration of mechanical ventilation, since we first did this in 2000, there's been extraordinary improvement. So it was fun for me to look back over the last, I guess, 40 years and see how our care has improved. And so I'm happy to hand the baton off to all of you, particularly the residents, to move ahead on the next 40 years. And when because I'll probably be in your operating, well, maybe not here, but the operating room in San Francisco, and knowing that I'll get even better care because of all of you. So thanks for inviting me, and happy to answer your questions. Yeah.
I think I'll start. First of all, Dr. Gropper, thank you so much for your wonderful review and discussion. We had a very similar opportunity, I would say, a few years ago with us when we first joined MPOG. Mm-hmm. We work closely with our surgeons and looking at NSQIP outcomes and where we can make some changes. And a number of years ago, we were identified as outliers for post-op pneumonia. Mm-hmm. So we were not in a good way, actually, in a bad way. So we had the opportunity to come back and look at what we were doing. And we actually also identified, when we first joined MPOG, that we were outliers in lung protective ventilation. So started a project. I see some of the leaders back, Laura India, who's going to present this work at IHI in December. And we just actually changed all our ventilator settings to default to 400 cc's instead of 600 cc's mm-hmm. as a start. We also turned on the EPIC Q, which isn't a red line, but it just pops up a best practice alert saying,
Yeah, we did our own. We have so many best practice alerts. I figured we better not.
I know, they're problematic, right? And then at the same time, we worked with our respiratory therapists to start pulmonary prehab in all of our patients who were coming for open abdominal procedures. Mm-hmm. And now we're exemplary from NSQIP. My question would be is, how often do we as anesthesiologists, or where do you see our opportunities in always... We look at our own databases so much, and one of I think our challenges and our opportunities is to combine with our surgical colleagues and figure out where we're at.
Well, you're exactly right. I think I've found them. I think that's also maybe, I guess other good things about having done this for a long time. I find a much more collaborative interest. I mean, so data for sure is persuasive, and it's not. I think if it were just anesthesia saying to the surgeons, "Hey, you guys need to do this differently," but I assume there's a chief medical officer, chief quality officer, or somebody where you get together as a group and say, "This is a way that we can improve practice." I mean, you've done a lot of that, and it's usually the trainees. When we were trying to change practices in the ICU, significant changes take about 4 years, which was sort of a generation of trainees, right? And once an intern comes in or first-year resident rotating to the ICU, this is the way we always do it. By the time they're chief residents, and they're rounding, this is, oh yeah, we always do this. And then that influences the faculty. So I think, of course, so I think you did exactly the right thing. I mean, of all the things I've done over my career, and I didn't talk about any of that stuff today, which was sort of practice change in the ICU. But the only way it worked was, I spent most of my time with nurses and respiratory therapists. It was not so much for the physicians. And, part of it is there's variability from week to week, different attendings, different styles. And so what I realized was we had to sort of insulate the nurse, didn't want a big, practice change. We change attendings every Monday morning. And now Monday morning, the new attending comes and changes everybody's ventilator settings. Like, I don't believe in that PEEP stuff. I mean, it's terrible, right? And so by keeping I like to think that the care of I would say that I want the care of the patient to be independent of whoever happens to be their doctor that day. And that resides with the people at the bedside, and they're passionate about it. They love to be involved. So I think, that's a big part of it. Of course, in the operating room, there's only one of us, setting the dial. We were discussing last night at dinner about, how do you use the data that comes from MPOG? So now we all are you sending individual providers their report? And it's still a work in progress. I mean, I'm in the operating room 1 day a week, and I do thoracic cases, and I look at it, and it's like, that I did 8 cases last month, and, 1 case is an outlier, so the whole thing looks terrible. So there's actually MPOG's Sachin Ketterpal, who, is in charge of it, just got an R01 to look at how do we use that data to affect practice change. And it's actually worked. For example, we have a resident-run quality project every year that's supported by the health system, and there's real money in it. I think it's $5,000 each, or maybe even more. And you choose 2 things. One is a department-specific thing, because obviously, ophthalmology or dermatology is going to have something different. And then one is a health system thing. But so, for example, last year we chose, optimizing antiemetics for every patient. And we would show it every time it ran rounds, and it really works, And, of course, not only did antiemetic use increase, but postoperative nausea and vomiting did decrease, so I think data is persuasive. I mean, you did exactly the right thing, and it's fun. I never thought I would enjoy doing things like that, but I really do. And so congratulations to you on that. Top left.
Thanks for your talk.
Yeah.
One of the discussions of the past 5, 10, 15 years has been the use of EIT to reduce perioperative pulmonary complications. What are your thoughts on that? And
the use of what?
EIT, electric impedance technology.
Oh. I'm not, familiar with it. To use it in what way? For monitoring?
It was for monitoring. Janine Cronish gave a talk at ASA a few years ago about, what she thinks could be the future, not future, but applications for it.
Oh, I mean, in other words, sort of ambulatory monitoring post-op? Yeah, no, I think it's a really good question. If you went to the ASA, there was like an enormous presence from GE and others. So what I think we have going for it is that most of the let me back up a little bit. We do a really good job of putting people to sleep, waking them up, bringing them to the PACU, and saying, see you later, right? I mean, and everybody looks good, right? And if you look at when do the complications occur, they occur later, right? And so the question is, so for failure to rescue, which is a really important one, so can we make that better? There's, as you said, there's a lot of interest, which is if we could just have ambulatory monitoring on patients. And if you went to the Rovenstein lecture from Dan Sessler, he sort of gave some controversial remarks about nurse anesthetists, and then he said, but where can we really be the experts as anesthesiologists? And he said it's taking this large volume of physiologic data that's going to come later and evaluating it. The only thing I would say is probably the expert of evaluating large volumes of physiologic data many days after surgery is going to be a machine learning algorithm and not, a human. So, yeah, I think we have to study it for sure. And see, can we identify early deterioration? As he said, taking vital signs once every 6 to 8 hours is probably not enough. And failure to rescue is one of the measures that's used to look at hospital quality. So I do think that there could be, we have to study it. And one of the challenges, of course, is going to be how do you deal with the false alarms, right? Because when we've tried, even with we recently had a couple bad outcomes in patients who are on continuous pulse oximetry. Well, there's a couple things I'll say about that. First is that oxygenation is not ventilation. If I can only have one thing, I'd rather have reliable capnometry than oximetry, right? Because it didn't work well. And one of the patients who had a bad outcome was because they kept fidgeting with it, and there was a problem with the pulse oximeter. And the response of the people monitoring was, that doesn't, that thing's broken, it's not really working, and then they stopped sort of paying enough attention to that patient. So I think absolutely, but we're just gonna have to figure out how to do it. There's, again, at the ASA, there was a lot in that space with Massimo and GE and others. So I think there's opportunity, but again, figuring out how to use it judiciously will be important. Good question. There was another question up in that area? Yes.
I'm curious if you have any insights into et cetera, et cetera. But when I see realistically in the ICU, every patient gets disconnected probably many, many times per day. Certainly, then they come to the operating room.
Yep.
They get disconnected. Transport is different. Then you move surgery around. Do you have any?
Well, yeah, I think you're right. I mean, it definitely happens. It probably depends a little bit on the patient, right? Patients that are breathing well spontaneously will do a little bit better, but I don't think we've ever looked at that specifically, other than, I think if you watch the respiratory